Thank you everybody for joining us today. My name is Graham Folds and I'm the Regional Director for Laerdal Asia Pacific and the Managing Director for Laerdal Australia and New Zealand. Today I'll be your moderator for this webinar. The SUN is a conference that celebrates collaboration, innovation, simulation and patient safety advancements. It is where best practices meet hands-on training and our simulation user network members come together. But this year, due to the pandemic, many conferences have been cancelled, including our SUN conference. Now, more than ever, our mission of helping save lives has been playing a major role to help train and support the simulation users and prepare them for the new future. So today we're excited to introduce SUN webinars on every other Thursday, starting from today until the end of September 2020. The theme of our SUN webinars will be the future of simulation, technology, engagement, and how they improve patient safety. During this session, if you have any questions, please send them through on the Q&A function, which you'll see at the bottom of your screens. We'll have 15 minutes at the end of today's webinar to go through these and have as many as possible answered. All attendees will have their microphones muted to minimize background noise, and this webinar will be recorded, so you'll get an email with a link to the recording in a few days' time. Today, we're privileged to have our speaker, Dr. Paul Frampus. Paul is well known to many people across the Asia Pacific region. He's a leading expert in simulation and patient safety. During this webinar, Paul will be sharing the importance of simulation as an educational tool for the healthcare workforce. Now, please, ladies and gentlemen, join me in welcoming Dr. Paul.
Thank you very much, Graham. I appreciate being here and look forward to participating in this SUN webinar, and I look forward to when we can be face-to-face again. So thanks again for the invitation. So today I wanted to talk about, I was asked to talk about thinking about the implementations of simulation as a patient safety tool. And I really want to focus a lot on what the differences are when we think about simulation as a pure patient safety tool. At times, simulation is thought of as a pure educational endeavor or a pure educational tool, but it kind of runs afoul and sometimes I think slows down what we can do with simulation as a patient safety tool as we move things forward. And that's kind of what I want to discuss over the next 40 or so minutes before we get into the Q&A and hear some of your opinions on the topic. So I want to start off with disclosures. I don't have any financial connections with any simulation-based industry or particular products. I do some personal consulting, but I don't think that will present a conflict with this particular material. The opinions that I will be talking about today are mine personally. They're not necessarily representative of any of my affiliated institutions. So with that, I need to go on to another big disclosure. For those of you from Australia, I think that you'll get this. There might be a few of you that like it and a few of you that want to throw some stones at me. And that is, I'm a huge Collingwood Magpies fan. Have been to a number of AFL matches in Australia, and I can't wait to get back and see another one. So I do want to thank Laerdal for this invitation and bringing us all together virtually and using this time of disruption insofar as the pandemic is going to continue good education and global sort of push of simulation so that we can keep our patients safer and improve the quality of healthcare around the globe. I want to thank you for tuning in and taking time out of your busy day to attend this webinar. I do want to say that when the pandemic is in the rearview mirror, if you will, I want to welcome you to Pittsburgh. If you come in the summertime, this is what it's going to look like, and it's a quite enjoyable place. If you come in the wintertime, this is more what it looks like. It's still an enjoyable place, but mostly from the indoors. But nonetheless, you're welcome to come to Pittsburgh as soon as travel becomes a little bit less restrictive around the world. So in talking a little bit about where we're going for this particular webinar, I kind of set it up to just give a brief background of the health system that I'm involved with and I come from. That's the UPMC health system. Talk a few minutes just about a background on WISER and our simulation program, and then move on to what is patient safety, talk about some of the size and the scope of the problem, and identifying simulation opportunities in patient safety, and figure out how can we maybe think about some plans of integration of simulation in patient safety in a meaningful way, and talk about some of the opportunities, some of the challenges, a few of the successes, and maybe a little bit of thought process for the future. So I'll start off with a brief background about me and my roles. Currently, I'm a practicing emergency physician. I practice at our Level 1 Trauma Center at the University of Pittsburgh. I'm the director of WISER, the simulation program, which serves the needs of the University of Pittsburgh and UPMC, and I'll get back to that. And then also, I serve in a unique role as the medical director of patient safety. And this sometimes gives me an advantage point that is unique insofar as I see things from the simulation perspective, but I am also overseeing a number of aspects of patient safety across our health system that I think gives me sometimes an advantage to implement or think about ways that simulation can be used in an innovative pathway of patient safety. I have some previous roles. Maybe some people would say I can't keep a job, or some would just, wonder about my pathway. I am a former paramedic, and I am very proud of that and maintain close to my roots with my paramedic friends. I had a failed career for a few years as a DJ. That's my brother and I with a DJ business that we had in the early 80s. I guess it wasn't a failed career. It just wasn't a career that was going to pay too much of the rent. And then I had a 7-year stint in the United States Navy, and I was an electronics technician, and I worked on radars and computer systems. That's where I developed my technical prowess and my geekism, if you would, as well as discovering I like teaching. So I was doing a lot of teaching back then when I was in the Navy before I transitioned to my paramedic and then physician career. So enough about me. Talk a little bit about UPMC and the health system that I work in. It's a very, very big health system, and it has 29 acute care hospitals with 8,400 licensed bed. We have about 600 doctors' offices and outpatient sites that we look after in terms of the places that we provide care outside of the hospital. We have about 6,300 affiliated physicians. And then we also have our own insurance company, our own medical insurance company. And that insurance company oversees the care of 3.8 million people. And I'm going to get back to why that is important. We have a huge staff, over 90,000 employees. I think it's like 92,000. And we have about 60,000 of them that we count as patient-facing employees, so somewhere within an arm's reach of the patient. And as you can see, our numbers down here, I'm not going to dwell on them, but we have quite a few inpatient admissions every year, and we have about 5.6 million patient encounters total, with about 250,000 surgical procedures. So it's a big health system. It's a monstrosity. Talking a little bit about WISER and how it's affiliated, you'll see on the left-hand side of the screen is the University of Pittsburgh. We work very closely with the schools of medicine, the School of Nursing, and the School of Pharmacy. And how WISER is attached, if you would, to the University of Pittsburgh is through what you think of classically with the university. It's about the schools that we interact with. It's about the students that we serve and help to create simulation-based education programs for. And we do research on the simulation-based education, as well as innovative education process and products that are moving forward. I already introduced you from a facts and figures perspective to the UPMC side of things, and what we're focused on as far as WISER goes in that arena is hospital support, patient safety, staff and providers, and a lot of professional education. So student education on the university side, but much more professional education of practicing professionals on the UPMC side. Those two entities join together to create WISER, and that's basically how we are structured and how we function on the day-to-day basis with our two major stakeholders. Today, though, we're going to talk mostly about those things that are on the UPMC side of the house. I'm going to set aside maybe for another day our work with students and focus on the patient safety efforts that have to do with the healthcare system. So I was wondering, and we wanted to use the active polling function to see how many of you on the webinar come from simulation programs primarily aligned with hospitals, and then how many of you come from simulation programs predominantly aligned with schools or universities. Answers: I know that many of you have a tough time with that, because like I know when I answer this for Wiser, I say I have, I'm both. I'm university and the hospital. I'm trying to get a flavor for where you come from most of the time with most of your efforts. So yeah, almost an even split, 51% for hospitals and 49% for schools and universities. All right, so let's keep going here. Just a few minutes or a few seconds about Wiser. What Wiser is we have a central location with about 1,600 square meters in the center of Pittsburgh, near our major academic hub hospitals. That's the teaching, education, development headquarters for Wiser. And then we operationally and administratively provide services to 8 different satellite simulation centers within the greater Pittsburgh area. Our technicians and simulation specialists, curriculum developers, and administrative staff support hospitals and their local efforts in terms of things that happen at the hospital offsite. And then when there's bigger programs or when there's development and research projects and stuff there at the main campus of Wiser, which is that 1,600 square meter facility that I was talking about. Wiser is accredited by the SSH in all areas. We've been accredited since 2012, and we were one of the earliest endorsed centers by the American Society for Anesthesiology, just to give some background on our focus at Wiser. We're a very busy place. We supported over 2,100 classes last year, and at the main campus of Wiser, we had 16,400 educational encounters, and that's one person coming for one scheduled piece of instruction. That's how we define educational encounters, and we had about 5,300 people in unique student roles throughout the year that came to us for various programs. So I think that we want to move on and talk a little bit more about the scope of patient safety issues. Many of you are probably aware of patient safety issues in the country that you come from. You may have heard from international news and so on. This is a global problem. There's no doubt about it. A couple years ago, there was a study done, and I think this got a lot of global press in terms of the patient safety issues in the United States, where the researchers declared that the 3rd leading cause of death in the United States was from medical errors. And that study underwent a lot of scrutiny in terms of whether it actually is that high or not. But the bottom line is, I think in that study, they were estimating around 250,000. Another study came up and said about 400,000 people die annually in the United States from medical errors. And I always say that whether we're off an order of magnitude, 10 times or not, there's far, far too many people that are harmed by medical care. Bringing it down to some more closely aligned research, this is an interesting statement from David Klassen, who's a big public health and patient safety researcher. 1 in 3 hospitalized patients in the United States experience adverse events. 6% of those cases, 6% of the 1 in 3, the adverse event causes an issue that is so severe that it has either permanent disability or death to the patient. And that's a pretty scary number if you think about it. Many of you have probably heard about the 2 Eras human study that was published in 1999, and then hard copy came out in 2000. And in this publication, it was early on, through a number of chart reviews and looking at data that was about 10 years old, or I should say the rolling 10 years before the publication of the report. They estimated 98,000. So 100,000 Americans die annually from medical mistakes. Now, this is, again, basically 20 years ago now. But even at 100,000, that's about 270 some people dying every day. So essentially, it comes down to a jumbo jet crashing every day, even with the most conservative numbers here that you see, this 98,000. Interestingly, in this report, simulation is mentioned 18 times as a potential part of the solution. Now, this was published by our National Academy of Medicine, is what it was called back then. So the point is, this is some of the brightest and best, most scholarly minds in healthcare in our country. Some of the brightest minds, and their reports and their foci are informing Congress and our government in terms of what's going on with healthcare. And they mention simulation 18 times as a part of the solution in this particular report. So what happened? Looking back over this time frame, 2021 years, I just, some of you may have seen my editorial in Simulation Healthcare. It was about a year and a half ago now. And I said in that, despite this, and I was talking about the Institute of Medicine report there's not been widespread, systemic, consistent adoption of simulation into patient safety efforts of hospitals and health systems. How can that possibly be? The brightest minds in our country have called upon us and said in 18 different occasions, 20 years ago, that simulation should be wired into the health system, if you will, as a potential improvement to slow down the harm that comes to patients when they seek care. And it's just, we're still not there. So what I want to talk about is some of the reasons why this can be. How can this be? Well, I'm going to give you the answers to the questions now. I hope you won't jump off the webinar, because I'm going to give you the answers to the test, and then talk a little bit more about maybe backing up some of my theories and thoughts on this kind of stuff. And I want to warn you, I might ruffle some feathers here, and I apologize for that ahead of time, but I think that we can have an open and honest dialogue about how things go. I think hospitals and health systems don't fully understand the capabilities as well as limitations of simulation. We're going to get back to that and talk a lot about that in the near future here. I think that hospital administrators, and when I say hospitals and health systems, I'm talking about the leadership, the C-suite, the exec suite, whatever you want to call it in your particular location, with who makes the decisions for the hospital. I think they think of simulation as an education tool only. And when you start trying to sell education in the hospital side of the equation, that is a very short conversation for a number of reasons. And I'll talk about a couple of them in a few minutes. They're fearful, and they know that simulation is expensive. At least it's expensive on the initial investment. The argument can be made that with the savings that come along with simulation and some of the patient safety improvements and quality improvements, that we can pay back with this investment. But at the moment, they're still thinking of simulation as an expensive endeavor. I think one of the big things that I would like to push is there is not routinely simulation partners that are helping with decisions about patient safety initiatives, decisions about whether to implement simulation or stop the implementation of simulation if it falls in an area that's outside the scope of what simulation can do. There's no real mandates in terms of government, payer mandates, etc., that mandate the use of simulation. And then lastly, and a big one that some of us in the simulation community would like to address more, is there's not convincing data that simulation can save money. And we can use the term save money, improve patient care almost interchangeably. But the bottom line is there's an unclear return on investment. Again, maybe this is part of the reasons why we haven't moved the needle in a systematic implementation process to get simulation rolling in the hospitals over a 20-year period. So let's switch gears here and look at the simulation side of things. We can't just throw bricks at the hospital administrators without looking closely and examining what's going on with our community. I'd say that we have been not able to provide a clear return on investment as a community. We have lots of simulation centers around the world, and each simulation center kind of focuses on what it wants to focus on. And even if we focus on the same thing, we probably do it a little bit differently, and we squander the opportunity to systematically figure out how do we make an argument for return on investment as a community. Simulation programs oftentimes are insular, and they're involved in the education things and do that quite well, but they're not aware of the true safety issues, or they're not aware of the big picture of safety and maybe just one area. So if there's a central line problem at your hospital or your care environment, you might focus on central lines, but but you maybe cure the central line problem, and then you don't know what the second and third and fourth and fifth big patient safety issues are. Or the other possibility is that because you have certain equipment or the availability of certain equipment, you want to simulate those kinds of things, whether they're needed or not at your hospital, because you think it's important. Simulation programs are immersed in education as the primary role. If you look at our journal on the month-by-month basis, you see things like realism and how important it is or not, or how to make it real or less realistic. We talk exhaustively about debriefing and the methods of debriefing and how do we make people comfortable and happy and maintain the safe learning environment, which certainly is important to get people to participate in simulation from the education perspective. But when we focus all of our time on that, it becomes hard to understand how do we integrate as a system into hospital-based infrastructure that is solely set out to improve patient safety. I already talked about simulating what they can and not what they should. And then the other thing is, this is the other side of the coin from the hospital side that I just showed on the last slide. I think a lot of times simulation is not viewed as a true partner in quality and patient safety. And people think of those sim people as the educators, as opposed to somebody who's at the table with a knowledge of safety science, understanding deeply patient safety, understanding deeply quality improvement initiatives on the healthcare side. As much as simulation and education is a science, so is safety and so is quality. And we need to get some people that are trilingual in the simulation-based education, as well as the safety side of things and the quality side of things, to be able to sit at these tables and make cogent arguments that simulation brings a high return on investment for the particular institution that is being purported for. So let's shift gears here and talk a little bit about patient safety. I'm going to start with asking, what's the goal of patient safety? There's lots of definitions of patient safety. I kind of cobbled together one that is my particular favorite, and that is simply reducing unexpected patient harm that occurs during the delivery of healthcare. So when patients and their families come to us, they really believe that we're going to take the best care of them possible, and we do as well. But many times, as I outlined back in my slides with the scope, we violate the principle. We let them down, and harm comes to the patient simply because they were seeking out healthcare. So patient safety is trying to evaluate, how do we systematically reduce the chances of harm coming to patients just because they showed up to get their care? No talk on patient safety would be complete without looking at the Swiss cheese model of patient safety and how it is factors into healthcare. If you look at this slide, up here is the beginning of an arrow. And in this arrow, there's always harm heading towards the patient. And the Swiss cheese model is basically set up so that, or it basically describes how each thing that we put in place from a patient safety perspective is designed to stop that arrow from eventually hitting the patient down here. So the more slices that we put into place in terms here, and the more we readjust and misalign the holes, the more likely we are to stop the harm from actually hitting the patient. So I want you to see, and this isn't supposed to be a complete, this is just an overview or an idea. How about the number of people that should be working in the staffing? What are the policies and procedures that need to be put in place, the equipment, the training, the surveillance system, and so on. The problem we have in simulation is everybody thinks of simulation here as a training tool only. And I think that we need to broaden it a little bit and make people understand that simulation is a great surveillance system. Simulation plays a great role in the procuring, deployment, and continuing education surrounded by equipment. Simulation can help with some policies, and I'll talk about that in a few minutes. Simulation can investigate staffing and the ideal roles and goals that people play in routine care, the ideal roles and goals people play in emergency care, and so on. So there's lots of possibilities for simulation for the future, but I think we need to get everybody thinking about that it's just a training tool. So typical uses of simulation, you all are familiar with this, and I just have a couple papers for background information, if you will. This one is about central venous catheter insertion in the intensive care unit and reducing complications. Many of you probably know the study. It's one of the really famous ones in simulation. The This one is about hospitals that have participation in their in situ mock codes have improved survival after in-hospital cardiac arrest. This is another one on a systematic implementation simulation led to decreasing the amount of medication errors in the hospital. And this is a big one. This is a big and important one because medication errors are really a big problem in the hospital. They oftentimes are as much as 50% of serious events or serious incidents, I should say, are targeted to or attached to medication errors. The other example I have is another one for resuscitation, teams in situ simulation in the pediatric environment and how that improves response to deteriorating patients and improved outcomes in the intensive care unit. All of these papers are representative of an amazing amount of work that has gone into these programs to get them rolling. But the challenge is they're implemented at one hospital and they're all at different places. So there's not a systematic implementation pathway to wrap it all up to make that return on investment. And the other thing that we need to think about is some of this is probably not even on the radar screen for improvement from a safety perspective, a quality perspective, or a risk management perspective. And that's where some of the difficulty comes in when we are passionate about what we want to do, but it's not necessarily aligned with the needs of the institution. So what I'm talking about is improved outcome to intensive care unit resuscitation in pediatrics. It is a noble cause. There is no doubt about it that we can better resuscitate children. But if we are not showing that we are reducing an error that costs money to make the hospitalization more affordable or more efficient, however you want to look at it, or if it's not on the top 10 list, if you will, of that C-suite, the executive suite's list of how of the biggest vexing problems for the hospitals, we're going to get eye rolls when we come and say we want to make a multi-million-dollar investment in the simulation, and we have to work on ways to align these things. Now, please don't misinterpret my words. I am not saying that improving resuscitation and ACLS skills and CPR skills is not important. That's not my point. My point is when we are trying to systematically implement simulation deeply into the hospital, we have to align our goals, objectives, and our return on investment package with the problems that are vexing to that particular hospital. So how do we know if we're doing the right simulation interventions? It's very easy. I got a single slide that shows you. We have to monitor the pulse of the organization. What do I mean by that? Monitoring the pulse of the organization comes in many different forms and fashions, but I kind of make this or put forward this analogy because it resonates with those of you that have either take care of patients or used to take care of patients. When we monitor the pulse, that's kind of one of the main things that helps us understand what we need to do for the particular patient. If we think of the hospital or the healthcare system as the patient, it helps give us some clarity in terms of what do we need to do to really fix this organization and bring it along in a way that patients are getting better, safer, higher quality care. That's the real question. You know, a long time ago, this was 2007, David Gaba wrote an article in Simulation in Healthcare. You could tell it's old because the journal still called the issues by the season that they were published. And this is another North American centric kind of thing that was going on at the time, but it was summer of 2007. And it's a good article to read from a perspective of looking at things that worked out in simulation, looking at things that didn't, and there's a whole discussion about that in this article, but I'm just going to pull out a couple salient quotes for this discussion. Using simulation to improve safety will require full integration of its applications into routine structures and practices of healthcare. Now, I don't know about you, but I can look myself in the eye and say, I've been the director of Wiser for 15 years. I've been working at Wiser for a little over 21 years. And I can say we have not achieved full integration of the applications and potentials for simulation into the routine structures and practices of all of healthcare. We need to get there. we need to get there, and that's going to help us as a guiding principle. But in 2007, David Gabo recognized that this was an issue. He also talked about some of the challenges early on and said the costs and benefits of simulation are difficult to determine, especially for the most challenging applications where long-term use may be required. I don't know about you, but in my organization, it is really tough to sell the long-term idea of we need to invest now and then monitor this for a long time to see if it pays something back. So we have to develop a foundational base of argument to be able to make those kinds of investments come true, at least at my health system. So I wrote recently, safety and integration into patient safety systems, the editorial that I was quoting earlier, and I called upon us in us as a community to partner with quality and safety experts of affiliated systems. Will catalyze deeper involvement with and share the learning with respect to the existing problems and simulation opportunities. Simulation opportunities, simulation limitations, the potential comes from partnering in a detailed way with quality and safety experts that are attached to the executive suites of your hospitals to figure out how can we use simulation as a tool to move things forward. I like this picture. I think that this is where we need to go. Simulation programs need to be hardwired into the system to function at max effectiveness for patient safety. So we really, really need to have simulation look like everything else in terms of the wiring of the hospital. It just kind of fits in seamlessly. Because my fear is, and my thoughts are, we kind of look like this really most of the time. We're kind of a bolt-on effort that doesn't quite look like it fits in. It does some good, it's functional, but it still doesn't necessarily reflect something that is fluid inside the hospital system that is done. So how do we find opportunities? I think that there's a lot of possibilities on the way that the opportunities can be found. Connecting with institutional data, as I've talked about, is one of the important things. Looking at the errors and the potential harm that has come to patients, that's the patient safety thing. Helping or addressing quality problems that the executive suite is struggling with. Looking at the lawsuits and paying attention to the risk management piece of your institution will help a lot. And then there's some other ways, looking at the things that are mandated by external agencies, professional networking, professional associations, I think. But I think if we focus on those top several bullet points, we will find a plethora of opportunities where simulation will declare itself to be the best tool for the job. So thinking about some alignment strategies, this is set up to represent, the basic everyday hospital somewhere in the world. Basically, you have a hospital president or chief exec, whatever you might call them in your world, and obviously there's going to be some vice chairs, etc., in this layer. But what I really want to pay attention to is this. There's somebody that looks at the physician and the physician affairs. There's somebody equally as powerful in the nursing side. And then there's always somebody that has to do with risk management, legal, and those folks. Department chairs of the clinical departments usually have a lot of power. And then there's the education department. And a lot of times simulation is aligned directly with the education department. But the challenge is, and the real sad piece of this is, usually the education department doesn't have much power. They're oftentimes underfunded and have a mandate that is bigger than they are staffed. Whereas the other folks that I've outlined here usually have bigger budgets and a lot more power. And then if you look on the right side here with the quality office and the safety office, then these two may be connected in your institution. They may be separate, but they usually have a lot of power because they are directly connected to the power brokers of the hospital because they're trying to fix the problems. They're trying to improve for making patient care better. They're trying to improve the quality. They're trying to improve the reputation of their hospital and so on. But the important thing is the simulation program oftentimes sits way out here and isn't really connected at all inside the hospital infrastructure. And that's really a shame. Because what we need to do is open up dialogue pathways. We need to open up dialogue pathways with the quality and safety offices. And I'm talking about having a seat at the table of quality and safety so that you know what's going on inside the hospital and you know what needs to be fixed for the future. And then you're postulating or thinking about how can simulation be used to transform this, or how can simulation be used to figure out what's happening next so that we can make good recommendations back to the leadership to solve these problems. And then once we implement these solutions and these simulation programs, we have that same dialogue in reverse, and we go back and we are in a fluid cycle of communications with the quality and patient safety offices of your institution. That is how we become partners in patient safety and quality. Okay, even sometimes when simulation isn't the right fit, maybe we can help to bring a solution to the table, or we can help people to understand what the right solution is. That is how we become partners at the table in quality and patient safety, which is connected to the executive suite of your hospital. So I'm curious for this next poll question, how many people are in regular contact with their patient safety executives and so on? So we're going to put up a polling question to look and see. So about half of you on the webinar basically said that you were from the hospital side of things. I'm curious that how many of you meet with your chief safety officer more than twice per year? Okay, so yeah, that's kind of what I thought was going to be the answer, is that the polling suggests that only about a third meet with the chief safety officer or the people in charge of safety in a given time frame. I said twice per year. But I'm talking really, if we're going to partner in patient safety, we want a simulation person, simulation leader at that table in that conversation on the monthly basis at a minimum to provide this. So I think it's really important. You know, when I travel around the world and talk to people in person, it's very interesting that I find that a lot of people don't even know the name of the patient safety officer or the chief quality officer of their institution. So that's how far disconnected sometimes simulation programs can be. And I'm not, that is not a commentary or a critique as much as just observation of how things are organized in many places. And we get so busy doing the routine pieces of simulation that we don't even understand why we're not making systematic improvement in bringing simulation forward in the integrated solutions for patient care. So getting access to data is really important. This is just basically a cartoon, I guess you will say, or a depiction of my inbox. Each week, I send a list of patient safety big issues, serious events to the system leadership. This type of information flows in your institution somewhere, and getting your hands on it and being a part of the dialogue that looks for the solutions is how it can happen. This is a big event report for us because it's a serious event, and it is defined as a event that actually causes harm to a patient. As you can see here, a serious event is defined as an event that causes harm. So now, that is my role as a patient safety officer, medical director of patient safety for the system. When we look back here, we're depicting about how does Wiser fit into this equation in terms of, you know, doing something or bringing solutions to the table. So I'm involved and I have some colleagues involved in risk management, quality, and liaisons to the departments. And if there's a role for simulation, then Wiser's looked at for a solution, and then we go through our development process, and our development process always has a function that is evaluating the results of what we did so that we can target and measure and then report the improvement back to the system. That's a critical part of anything that you do in terms of when you get called upon to bring a solution with simulation to your health system. Make sure you're gathering the data of measurement that you can move things forward. So one of the things I think that we need to talk about is challenging the sacred cows. And what I mean by that is it's really, really hard for us to move off as a simulation community to move off of that traditional stronghold of thinking about education and all the details that go along with education, and stepping backwards to look at how can we implement simulation as more of a systematic approach. And it becomes tough, it becomes challenging, and some people, particularly those that are not in the operational space or don't even appreciate the gravity of the harm that is coming to patients, they kind of get dug in on that education side. And sometimes I think that prevents us from moving forward in a rapid way. So I think I want to finish up with thinking about simulation as an assessment tool. Those in situ programs that we talked about before, looking at simulation as a systems evaluation or the environment evaluation, and then look at things like individual contributions and teams, perhaps as an afterthought, okay? And because what I'm trying to say is we're flipping this on its head, because typically we think about the individuals involved and what are they contributing to the problem. And I'm suggesting here that there's more value in simulation as an assessment tool when you're looking at the systems and the environment that they're done. When we do our in situ simulations that we are invited to in the hospital for looking at different things, different hospitals within our system want to focus on different aspects of things where they think some of their problems are, or sometimes they're just saying, go and see what our problems are. But basically, we use our in situ simulations to identify latent threats and find opportunities. But when we do our in situ simulations, we do a debriefing and a discussion and all that kind of stuff. But our training functionality in that role is very, very minimalistic. We're certainly not talking about the depth of compressions and that level of detail after a in situ simulation, because we're really looking to identify the needs for system improvement so that we can give reports to the leadership of that particular hospital inside of our institution that allow them to make informed investments and changes. So in other words, we need to help them understand some of the programs that they have in place for quality and safety are good and they should leave them there. Some of them are not paying off the dividends that they hope and they need to change them. And maybe some they can even do away with. And what that allows is us to be advisors to senior leadership, the executive level at a particular hospital, and guide where they should prioritize and where they should invest for the future to improve their patient care. So we do an on-site debriefing. We thank people for participating because we certainly want to have a great relationship formed with the people that we touch and come in contact with the in situ simulations. We give them a brief explanation of the importance, and we give them a thank you card. We give them a thank you card that helps them to understand that we're not there to evaluate and judge them as people. We are just trying to help them, help their role as providers improve, but really we're focusing on the systematic improvement so that we can provide a better environment for them to provide their care. So that is what we do. The feedback on performance is at a very high level, teams at the most, and it's very, very brief because we have to be very sensitive to clinical operations. And if we go in and do in situ simulations and are not cognizant of the fact that we are disrupting the clinical care environment and keeping people from working, and we go through our normal long debriefing processes and try to figure out everything, all of a sudden we look like we're not team players. The people in the exec suite think that we don't understand the real issues facing the clinical topics and things moving forward. We do video our simulation in situ simulations. We go back again. We don't focus on individual issues and problems of individual healthcare providers. We are looking at the timing metrics and the equipment solutions and so on to let people identify the systematic issues that are facing the particular unit where we are providing this evaluation. So that's about it. I'm out of time. I maybe even spoke a few minutes too long, and I'm so sorry for that. But I want to just kind of summarize a few things. And one is I want to challenge the simulation community to step it up and become a true partner in the patient safety endeavor, the way I talked about it before. That is a true partner at the table, the highest level of influence that you can get in your hospital that's associated with patient safety and quality. I want you to think about how to develop the sources of information for your safety opportunities. What are some of those emails that fly around that you could use and you could get involved with the discussion? What is the real problems that are vexing your particular institution? Not one or two. What are the top 10 things that are causing pain for your executive staff with regard to quality and safety? That's where you put the focus. And I want to challenge you to think about that. And then when you get involved in this discussion, don't think of, I'm a hammer with simulation looking for nails. Just think about, is simulation part of the solution? If it is, create solutions. Make sure you're evaluating it, make sure you're reporting it and telling everybody what you're doing. And then the last thing that I want to talk about is tell your story. Go to the mountaintops and talk about your solutions and your simulation program and how it's impacting patients at your hospital every opportunity and every chance you get. I have a picture here of a patient safety report that we're getting ready to release on Friday, and it is quantifying all of the patient safety efforts that we've been doing at Weiser over the last 2 years. And it's a publication that's going to go out to anyone who wants it. If anybody's interested, just send me an email. I'm going to give you my contact information on the next slide. But we're sending it to our executive staff in print. We're sending it to our boards of directors of all of our hospitals and so on, so that we can tell the story of Weiser's contributions to patient safety and understand that we are a true partner in this endeavor. So I really, really want to thank you for your time and attention to this webinar. I look forward to when we can meet in person again and talk about some of these things. There's a ton of contact information for me and for Weiser up on the screen, and I look forward to hearing from you. And I do want you to notice, again, the Australian folks will appreciate this more. There is gear involved in being a fan, just like, different sporting events in America. And I am proudly sporting my Collingwood Magpie t-shirt there. And I know that you might think that it would really be sick if I had other pieces of apparel from the Magpies as well. But, it's cold in Pittsburgh, and oftentimes I bust out my Collingwood Magpies scarf to keep it warm. So thanks. Hope to talk to you again. I look forward to the questions and answers. And until we meet again, happy simulating.
Hi, Paul. Thank you for an incredibly insightful and amazing presentation on simulation, the role of patient safety. We have a number of questions, but before I get to some questions from the panel, I probably should point out, with that Collingwood scarf and being an avid Hawthorn supporter, and apologies for those people not from Australia and those people who don't follow Aussie rules, but someone should have mentioned to you when you came to Australia, first of all, you've got too clean a set of teeth to be a Collingwood supporter. You're too handsome a man to be a Collingwood supporter. But anyway, we'll move on from that. First question from the poll. If you were to give us as the audience 3 simple pieces of advice on how to best link our simulation programs to the patient safety officer in a hospital, what would those 3, and you've answered this during the presentation, but what would those 3 pieces of advice be?
Yeah, that's a great question. I would say that don't lead with simulation. My biggest advice would be to lead with a relationship. Establish the relationship, start to develop some understanding of the safety science and the process of safety. Just like simulation has its own vocabulary and its own taxonomy and its own glossary, patient safety does as well. Quality does as well. And when you can talk the lingo and the language and understand some of the charts and understand some of the information, then it becomes easier to form that relationship. So I think number 1 is the relationship. I think number 2 is be modest about what you can accomplish and be honest. The fact that we can simulate everything is not a good strategy to lead with. Think about, how do you apply the simulations to that exact problem? Or be also very wise if there are problems that are troubling your exec staff that you don't think simulation has a central role in. Offer an alternative, because the last thing you want is to get funded or push forward with the simulation program that doesn't track results. The last thing is, or the third thing, there's many, but you asked for three, I'd say is make sure that in any effort that you're bringing your simulation program along in is that you are evaluating it somehow, and you are being able to evaluate your impact, evaluate the quantitative effort that you are putting into the program so that you can feed it back to your leadership and the exec staff of the hospital.
Thank you. That actually links very close into the next two questions. What data does the CEO or the patient safety director want to see? And then I'll actually combine the third question. How do you show return on investment of your program?
Not easy questions. Okay, we'll start with the CEO. Let's not talk about the CEO. Let's talk about the chief quality officer, the safety officer, and the type of data that is in the reports that I showed you depictions of from my email. So every week, my corporate safety team is looking and evaluating at many of the patient safety reports from across the system. And there are far too many reports to say, give all the data to everybody. So we have to be very, very careful, because the execs, we only have their attention for short periods of time. So we want to make the biggest bang for the buck. To give you some idea, last calendar year, we had 143,000 incidents entered into our patient safety system. That incident doesn't mean something bad happened to a patient, but it's the feeding system that begins the process of investigation and figuring things out. I told you the definition of safety of a serious event. That is actual one where harm hits the patients. We had about 730 of them in last calendar year. And the execs, that's still a big number for them to chew on. So then we start to look at data from a perspective of, what are we doing to lessen those entire numbers? And then of that cohort of 700 and some patients, what are the ones that are the most likely that need to be referred up the food chain to the offices of the chief execs? And they are things that resulted in horrific patient outcomes, those that are associated with outcomes that might have a media implication, or they cause some kind of potential problem for accreditation for one of our hospitals. That's the type of data that gets sifted on the sort of population level, and then on the group level, and then at the individual case level. The return on investment, I have yet to find any system or any particular program that has been able to really demonstrate return on investment in a systematic way. There's been a number of attempts and a number of great works that have been published in the simulation literature demonstrating some of the return on investment for individual programs of simulation. Like the Central Line study that I talked about before, they have a couple companion papers associated with that series that defines about a 7-to-1 cost ratio in terms of reduction of expenses associated with the errors for the dollar invested in the training program. There's a number of studies like that, but they all look at one piece of a program. When we talk to people at the exec level, people that their spreadsheets are looking at millions and billions of dollars, we have to categorize or make the better return on investment thing at the system level. And that's harder to do when all of the reports that we have are sort of one-offs. So I think quantifying your efforts is one thing. And then the other issues, in depending on the program, if you can identify programs that lend themselves well to saying, yes, this savings for this reduction in error netted in this, you certainly want to keep track of that. The challenge with that is they are few and far between, because as most of us know, many of the serious events don't happen very often, and that's a very good thing. But we have to be monitoring how much does it cost to make sure that that never happens. And that's where the challenge lie in trying to concoct a return on investment just for simulation. The other big challenge that we really need to face in the simulation community is that rarely is simulation or education the sole solution to any patient safety problem. So we are part of a bigger picture of how do we bring in policies, procedures, staffing, equipment, training, etc., that reduce the harm coming to patients.
Yeah. A couple more questions, and we might go just a little bit over time. We've utilised simulation as an educational tool and systems testing tool for our COVID-19 upskilling and readiness for our hospitals. We're the busiest we've ever been in 3 years. We need to capture this and proudly promote our achievements. How would you suggest we go about this?
Yeah, as soon as COVID started heading on our shores, I directed my staff to make sure that we are keeping a list of each and every single thing that we did for the COVID endeavor, and how we need to. The problem or the challenge is 6 months from now, you don't remember all the little things, and the little things you probably spent a lot of time on need to be cataloged and thought about right now in real time. If you get a hold of our safety report that we're going to push out on Friday, we actually documented a number of the COVID just-in-time things that we were able to support the system. If you go back a few years, I think, I forget the year that we published it, we have an article in the journal Simulation in Healthcare, the special issue that ran on highly infectious diseases when the Ebola epidemic was starting to become a global concern. There was a lot of scrambling that went on to shore up systems and so on, and a lot of simulation centers pitched in on that as well. There's a number of recommendations in that particular issue of Simulation in Healthcare, and if you read our article in there, we talk about how positioning the simulation center as a solution finder for many things puts you in a powerful position inside of your institution. So I would definitely catalog what you're doing. I would definitely quantify it in terms of the manpower, the person power that you've put into it, the costs associated with it, and so on. And I would prepare a special report that you send up to your leaderships to demonstrate your contributions to that endeavor.
Fantastic. Thanks, Paul. We'll need to bring the meeting to a close now. We have a couple of outstanding questions which we'll forward through to Paul and hopefully get a chance to respond to. Once again, we'd like to thank Dr. Paul Frampus for his presentation today. That was fantastic, insightful. You've got some fans from the Brisbane Lions, Hawthorn Football Club, and a couple of others there questioning your judgment, but that's okay, Paul. Also like to thank our attendees for joining our live webinar today. We will be sending out an email with a link and access to the recording in the next few days. Our second webinar will be on the 2nd of July. Dr. Nancy Sadka, an emergency physician from the Northern Hospital, will present on improving systems and transforming culture. Please visit the LAEDA website for further information on some webinars. Once again, a big thank you to Paul and everybody for attending, and see you at our next webinar. Take care. Bye.
Thanks much. See y'all soon.